Welcome. I'm Jess Gomez from the Intermountain Medical Center Heart Institute, and today I'm joined by Dr. Jeffrey Anderson, a physician and researcher with the Intermountain Heart Institute, and we appreciate you being here. You have been involved in a lot of research over the years, and you have an exciting study that you're looking at statins in a busy hospital environment. Tell us a little bit about it.
Yes, well, we've known for many years now that statins are life-saving. They reduce cholesterol effectively with few side effects, and we also know they reduce the risk of heart attacks, strokes, and problems in the arteries to the body. And so we wanted to look to see how well we're doing, because now the guidelines are very strong. Those kind of patients that come in with a heart attack, a stroke, an arterial disease event should be on a statin. And more recently, we've said a high-intensity, high-dose statin, because you get the maximum benefit out of that. So we said, how are we doing? Where do we need to improve?
That's interesting. Tell us a little bit about the study. What was the methodology that you used?
Right. So we searched the Intermountain healthcare database, electronic medical database, for all the patients that had had one of these events, discharge on one of these events, over the last 18 years. And then we divided it up into 5-year segments. So 1999 through 2003, 2004 through 2008, 2009 through 2013, and then from there to the end of 2016 to give us 3 years of follow-up. And we asked ourselves, were they discharged on a statin? And was it high-intensity statin or not? And then we also looked at the outcomes as well.
Well, let's talk about the outcomes. What did you find?
Well, we replicated the finding we generally know, that if you're on a statin, you do better than not, and if you're on high-intensity statin, you do the best of all. But we found that many patients weren't on optimal therapy.
How effective were physicians in prescribing the statins, and was there improvement over time?
That's a great question, and the answer to that is it depended on whether you had heart disease, stroke, or peripheral arterial disease, and it did improve over time. So those, for example, overall, about 60% were on a statin in the most distant period of time. The middle period, it went up to 70, and now it's in the 80% range, which is good improvement. We would like to have it 90, 95, but we did best with coronary disease. Currently, that's in the 90s. We've improved with the stroke group, and currently that's about in the mid-70s. And we've also improved with the peripheral arterial disease patients, but that's still only in the 40s. So we have a big gap, particularly in those peripheral disease and some with stroke. But high-intensity statin, that's only being prescribed to maybe 30% of patients, even now, and so we need to emphasize that so we can get the best outcomes.
Why such a low usage rate?
Well, I think what's helped us is that we've had a discharge medication program in the coronary patients, because we're doing very well there. The others maybe haven't had that. And I think that's something that we could add, that is they have to opt out rather than opt in when you're discharged. You're on a statin unless you say, no, patient can't tolerate it. And also, you're on a high-intensity statin, which doesn't cost any more. We now know it shouldn't really cause much in the way more of side effects. And also that it shouldn't be a problem in terms of cost.
Yeah. What interesting nuggets did you walk away from this study with? Anything interesting in all three groups, or any takeaways that you might stand out to you? Well,
the takeaways are that we found that you do better on high-intensity statin, and that you can get up into the 90s. We showed that. It's just a matter of, I think, planning and getting doctors on board and explaining to their patients why it's important to take these medications.
That's great. What are the next steps for you in terms of this research?
Well, I think now that the guidelines really have come online very strongly, there's no excuse for not doing this. And we need to keep following this and tracking this. We need to get electronic medical record discharge forms available for all of these patients, physicians to use them, to remind them, and even more or less to nudge them towards prescribing optical therapy.
Well, that's fantastic. Congratulations on your great research, and thank you for joining us today.
Happy to do it.
We invite you to meet with Dr. Anderson, talk with him about his research along with our other clinicians from the Intermountain Heart Institute, and to come by our booth in the exhibit hall at ACC 2018. Thanks so much for joining us. Have a good day.